Good
Rekha, over
morning.
to you.
Good morning. Welcome to the first unconference of Life Sciences Healthcare Innovation Forum. And all of you know the Life Sciences Healthcare Innovation Forum is a community brand. In the past has brought in a lot many interesting events, discussions, roundtable, policy talks. Now, for the first time, we are coming out with this unique formatted unconference way, wherein we are taking the most contentious topic of combating COVID-19 through technology. We have a very interesting follow-up of speakers and interesting topics to be discussed, completely federated through the audience poll. People have suggested close to 90 topics to be talked about, and they selected 12 major topics. And then finally, we have to bring down to 4 topics for the paucity of time. I hope all of you will have a great time. Without much ado, I would like to introduce to the opening keynote speaker. Ms. Rekha M. Menon is the chairman and the senior managing director at Accenture in India. She is the current vice chairperson of NASSCOM. She is a leading industry voice on industry advanced technology-led innovation and socio-economic progress. Ms. Rekha is the vice chairman of NASSCOM and a member of National Council of CII, the National Executive Board of AmCham, and USIBC's India Advisory Council. She's also on the board of governors of her alma mater, the XLRI School of Business, and 2 not-for-profits, Pratham Books and Aksha Foundation. Rekha regularly features on lists of most powerful women in business in India and is recognized among the top 10 LGBT ally executives globally. Thank you very much, Ms. Rekha M. Menon. We welcome you on to this conference. I leave it to you to go proceed with the conference.
Thank you. Thank you, Raghu. Well, speakers and participants, a very warm welcome. I hope all of you are staying safe during these very trying times. And I'm very excited about this conference because if I look around, it's rather fair to say that a nation's socio-economic progress can be measured by the health of its citizens. And over the past several decades, we've made significant progress. The Indian healthcare system has evolved. Life sciences have evolved, especially when we consider our performance on key indicators such as life expectancy, infant mortality rate, and maternal mortality rate. Or if we look at how we've managed to curb the spread of some diseases, especially like polio, almost eradicated it. Yet at the same time, India stays a good distance away from providing equitable, quality healthcare for all. And that's a sustainable development goal that India has committed to. There are, of course, significant challenges that continue, whether it's in the healthcare value chain, whether it's gaps in healthcare infrastructure, a divergence between rural and urban availability, and an acute shortage of skilled healthcare professionals, inadequate public funding, to name just a few. And as professionals focused on this sector, I don't need to tell you this. You know all these stats. You know that we have one of the lowest density of doctors across the world. We have one of the lowest healthcare spending as a proportion of GDP. And individual households largely shoulder the burden for services when they are available. The current COVID crisis has really put the spotlight on what we've known for some time. And it's done through the dramatic manner. So while healthcare workers are at the front line doing a heroic job, in India and across the world, the entire healthcare system is being pressure tested. And it's cracking at the seams. And not just in India, it's cracking at the seams globally. And given that scenario, the critical role of technology in bolstering the system has never been more apparent. Whether it's enabling healthcare providers to mobilize their workforce better or deliver virtual care to those who can't visit hospitals, or accelerate distribution of critical supplies, or automate manual tasks to free up critically needed staff. Those are all just examples of where technology is already being used. But there's a huge amount more that can be done. Technology continues to be applied in a very limited way A lot more could be done to leverage emerging deep tech for improving healthcare systems and enable the prevention, detection, management, and cure of pandemics like we are in now, COVID-19. But more importantly, what we learn now could also then be used for the mid and long term, right, for healthcare. Because advanced technology, just a few examples, could easily improve health awareness and education efforts. We have very low healthcare literacy in this country. Technology could be used to provide more power to the edge by equipping local healthcare centers, whether it's with smart low-cost devices or creating platforms that facilitate remote consultations or local decision support, or even monitoring health-related wearables. Third, it could democratize diagnostics with affordable tools. Fourth, it could enable policy development and resource reallocation, with a combination of first generation and advanced technologies, computing bringing together intelligent data and systems. And fifth, it could engineer the ecosystems to tap into the collective capabilities of the government, technology companies, not-for-profits, and startups. Technologies such as APIs, microservice architecture, blockchain could easily help build and run those ecosystems. And as India finds solutions for ourselves, we could also take the lead here for the world. We have absolutely the best technical talent in the world. We have the second largest healthcare consumer base. And now we have a perfect storm and a trigger, which is COVID-19, that we can act on. So as a tech ecosystem, I see us having a big responsibility. We have to partner closely with the health community. We need to partner with research and academia. We need to partner with government, and more entrepreneurs need to jump in, but we need more funding and investment. We need policy support. So there's a long list of things that we could do and need to do. Speaking on behalf of NASSCOM, NASSCOM is committed to bringing the ecosystem together and to help enable it for this country. And this unconference is a great example. And thanks to Atul Batra and all the entire team that worked to make this happen. The community driven, with a bunch of sessions submitted and voted by the community. And this is the power that can really unleash innovation and change. So you are all the innovators. Let's get to work, and all the very best. With that, back to you, Raghu. Raghu, can you hear me?
Thank you very much, Ms. Rekha. And it's a wonderful insights into, and also sets the right context for this session. Now I'll move on to the next session. To proceed us, take us through the next session, I would like to invite Mr. Aravind Seth, and he's a board member of Narayana Health and HelpAge India, Nut Foundation, and Give India, and also ex-chairman NASSCOM Foundation and British Telecom, and a wonderful person, well connected across the healthcare world. Mr. Aravind, I request you to introduce the next speaker and take us through the entire proceedings.
Thank you, Raghu, and thank you, Rekha, for a wonderful setting of the scene. We now have Dr. Devi Shetty, who actually needs no introduction at all. And this session will go on for about 20 minutes, at the end of which we will have some question answers from the audience. So Devi, I know you're known as Dr. Affordable globally, using technology. That's a given. The question is now we need those solutions now to help us get through this crisis, and then get to the new normal later on. I'll just make a couple of things which for you to pick on. For example, social distancing is not something that was the norm. We've broken the trust between two human beings right now for the time being. How can we use technology for that? So that's just a lead-in. But I'd like you to give us, before that, because there's a lot of WhatsApp university out there, which everybody knows from. So maybe you want to start off by giving what's the real picture for all of us. and then build on top of that as to where technology can help us in the short term and in the medium term. I don't know whether there's a long term yet.
Thanks. Can I start, Arun?
Please, all yours.
Yeah. Thank you so much, Arun, and thank you so much to the organizers for the opportunity. First of all, I would like to give a message to all the budding entrepreneurs, startups, that whatever plan they have for the healthcare intervention tools, software, various things, what they want to do, they should not revolve it around COVID, because the epidemic will disappear in no time. I don't know whether it will take 1 month or 1 year. And what do you do with all the investments and all the effort you put in when the epidemic is not there? And also, you have to understand how this industry works. I'll give an example. A month ago, the debate was entirely about ventilator. Now, everyone jumped into making ventilators. And the lot of new technologies emerged to make different new type of ventilator, connecting one ventilator to the other ventilator. But very few of you have seen how the ventilator works in the ICU at 2 o'clock at night. We have busy ICUs with 200 bed, 300 bed ICUs. And it's a very stressful place to work. When we buy a ventilator, we keep on buying the same ventilator, not because we like the company, because our nurses are familiar with all the buttons and the switches and the idiosyncrasies of each ventilator. Every time we buy a brand new ventilator from a different company with the different configuration, invariably we land in trouble. And when the ventilator malfunctions, the result is in 2 minutes of malfunction, you have somebody brain dead. Some intervention. Can I continue?
Yeah, please
Okay.
continue.
Yeah. So if you are designing a ventilator for a COVID ICU, my request to all the entrepreneurs is that do not design it for the COVID ICU. Design it for a ventilator during peacetime, because COVID ICU is the most stressful place for the doctors and nurses to work. Because for the first time in our life, normally when as doctors and nurses, when we are in the ICU, our only intent Hello, can you hear me? Okay. So essentially it's a very stressful place. In that kind of a situation, you come up with a brand new ventilator which has never been tested. It is not the ideal place. So, and the worst thing is, all these ventilators, when they come out to the market, who's going to buy it? Next 5 years, believe me, there is enough, and nobody is going to buy a new ventilator for the next 5 years, because everybody bought that many ventilators already. Now, more than anything else, take it from me, every hospital in India is broke. They have no money. Whatever money they made all these years is finished in the last 1.5 to 2 months. So the last thing they want is to acquire a new machine. So I feel very sad when people have spent so many hours of their hard work and so much of money in trying to develop all this technology. So my advice for all the entrepreneurs, if you are trying to develop a product, do not revolve around COVID. If it helps COVID, it's good, very good. But when the epidemic is over, do you have a market? because it's a lot of effort. You are lifelong, so much of money is invested. Now, coming back to what is required in terms of essentially, why are we doing all these tools? We are doing the tools to make healthcare safer for the patient. There are only 3 strategies for us to do something in healthcare. Make healthcare safer for the patient. Second thing, make healthcare accessible to the patient. If every patient has to go to a city to get the healthcare, that is not the best solution. And make healthcare affordable to the patient. Then, more than anything else, make art of delivering healthcare to the patient an enjoyable experience to the doctors, nurses, and medical technicians. You may come up with a fantastic tool, but if it is so difficult for us to use, it is of no use. You would have the electronic medical records of US cost billions of dollars. They really cost billions of dollars. Now, electronic medical record, EMRs, are one of the top reasons for the doctors getting fed up of the profession and doctors getting burnt out of the profession after spending so much of money, but they have no options. So essentially, when you are designing a product, there are certain criteria. You should have a very clear objective. And the next clear objective is always find a hospital as a partner. Generally, the tendency is you have something in mind about healthcare. You identify some retired doctors, explain to them what exactly you want, and he will come up with his own advice what needs to be done. The most important thing is when somebody says, I will help you to develop the product, you should ask one pointed question. When the product comes, are you going to buy it? If he is not going to buy it, don't take his advice. So it is very, very important that the partner is a large hospital, not an individual doctor, because the decision on buying is made by the hospital. Of course, the doctor's input is very important. And the hospital should have preferably some kind of a skin in the game. Either they get some preferential shares or something so that they have an interest in it. Otherwise, they look at you as an intruder. And if he is willing to, if the hospital is trying to partner with you because you're giving them some money for this work, don't take them as partners. So these are my suggestions. Now let me come back to the actual 1 minute. Let me just one second.
Raghu, how are we doing on time?
I can't hear you, Raghu.
We have 8 more minutes to.
8 more minutes. Okay, let me just 1 second.
Then we have a Q&A with you.
Sure. So the what are the products you can think about? I will give you some of the simple examples. One is a tele ICU product. COVID or non-COVID ICU, it is desperately required because today when you talk about a hospital, 10% of the or 20% of the hospital beds are ICU beds. 10 years from now, 90% of the hospital beds will be ICU beds. That is the largest growth segment in healthcare, ICU beds. Now, when that happens, the most important change what will happen is the shortage of critical care specialists, intensivists. And intensivists, if you tell them that they have to stay at the ICU 24 hours, you're not going to have anyone working for you. Let the intensivist stay at home and they look at their the laptop or a mobile phone. Let them monitor the patient in the ICU. And if this is done, this will make healthcare safer for the patient and comfortable for the doctors. Because essentially, the moment you say doctor has to be there physically, then you have a limitation in scaling up. The other tool is an electronic medical record. You have to, young entrepreneurs, really think about getting an electronic medical record. Doctors like to use, and doctors have very clear thought exactly how the electronic medical record should be. First of all, doctors don't like keyboard. They hate keyboard. So it should be based on the touch. Then the electronic medical record, when you give it to the doctors, if you say there is an instruction manual, they will throw it at your face and they are not going to use it. It should be very intuitive. So if you can accomplish these two, and the third thing is, if you want them to buy the EMR, they're not going to buy it, not because they can't afford, because they don't know whether they like it. You could say that pay us as you use it, like a pay-per-use model. If you build on these three criteria, believe me, you have a big market. And one of the things I would like to request all the entrepreneurs here to develop is a new cardiac monitor. Yeah, I'm sure you have visited ICUs. You see one big computer-like thing hanging near the head end of the patient called cardiac monitor. You may not know that costs between 2 lakh to 8 lakh rupees. Why is it costing 2 lakh to 8 lakh rupees? Because each monitor is an independent entity. And what it does, it just takes the data from the patient and displays it in the monitor, like any other monitor. We have in one building 300 ICU beds. So we have 300 such monitors. All you need is a software to get the data from all the sensors from the patient, and one processor to process all the images, and a dummy monitor is displayed near the head end, and you can do all that. And then it will hardly cost 10,000, 20,000 rupees. Now, why this doesn't happen? Because there are only 3-4 players in the market, and they have the monopoly, and they don't want to disrupt the business system. So fortunately in India right now, we are not saddled with all these draconian regulations of patient safety, and which is meaningless. So it is, market is still open for the entrepreneurs to design something. Then let me come back to something very, very important, extremely important. There is no market right now. There is no product. The biggest problem we have, you must realize that the patient in the ICU is not taken care by the doctors. They are taken care by the nurses, and nurses come from different regions, and their English is very, very poor. Because the English is poor, they have a problem in communicating. And when they have poor communication, patients are unhappy, doctors are unhappy, they don't have the self-esteem. If you can come up with a software, a simple app which can use in a mobile phone, there are only 300 questions patient ask. If the software can ask 300 questions and they answer in English, and when the English is wrong, the software will correct it, and they can keep on improving. A simple app like this can really transform the way patient is taken care by the nurses. I have many other ideas. I think we are running short of time, so I'm at your service. Feel free to ask me any questions. Arun, I can't hear you.
Arun, you seem to be muted.
Yeah, thank you. I've been unmuted. Yeah. Thank you.
Sorry.
Thank you, Devi. Devi, that was absolutely fascinating, the way you described it. And so we are going to move very quickly on to questions. Otherwise, we'll run short of time. But I'm pretty sure the audience is going to have tons of questions for you, Devi. 10 minutes is not going to be enough. But Raghu, we'll need to find a way to get to Devi and do him. And Rekha, just if you notice that this is all what we were doing called remote infrastructure management. Now we call it remote patient management.
Yes.
We have a new category called RPM. And by the way, Rekha, we should give Devi honorary social sciences degree, not a doctor's degree.
Not just honorary social sciences degree, I would say frugal innovation and frugal technology, use of technology ideas. So all of that.
Maybe you've been given a new honorific today.
Thanks.
So
Thanks.
can I get the questions are coming? 1 second.
Okay.
Devi, the first question is from Chandrasekhar. Saying we at Watson.in and CureTail.in are making reusable face shields which can be sterilized and reused, making disposal of film-based shields thrown out, avoiding piling up of plastic medical waste. Is this something that is needed, or what would your thoughts be?
I would use it. The reason is, anytime we make these reusable product for this dreadful disease like COVID, you are going to infect these poor class 4 employees working in the hospital. They have no idea about COVID. They are the ones who are going to clean it, and they will get infected. And the reality is, the visor, what we use it, that costs some 40-50 rupees. It is really not worthwhile trying to reuse it. So we have made a policy that we are not going to reuse any of those. This reusable thing is very, it is okay when the product costs 5,000, 10,000 rupees, not when it costs 30 rupees or 100 rupees. Not worthwhile. Yeah.
Thank you, Devi, for that. Then I think somebody, Shubhendu Patnaik is saying, tele-ICU is really innovative. Does that mean the patients will be expected to have ICU set up at home?
See, the ICU setup at home is nothing to do with the tele-ICU. What we are, ICU setup can be run at home, but there has to be a nurse there to take care of the patient. And the doctors can monitor the patient from remotely for a chronic patients, not the acutely ill patients. Chronic patient who had a stroke, they're recovering from the stroke. Those patients can be managed at home. What we are looking at is a acute ICU, where patient who's desperately unwell has come to the ICU, or a patient who had a heart operation or a brain operation, they are recovering. So this is what we are looking at.
Wonderful, Devi. And just since you used your favorite comment of 90% ICU beds, sadly we are at 100% today. But
Yes.
I hope we go back to 90%.
Yes.
I'm sure we will. So then Bonnie Dave is asking your thoughts on the boom seen in walk-through sanitizing chambers. How effective are these walk-through sanitization chambers?
So far, there is no evidence to show that, see, anything which works in few seconds, you assume it doesn't work. Because you have to realize that these are very live organisms. If there is something which can kill them in few seconds, there is something wrong. So all these things, it looks very impressive, but there is no evidence yet to show that it works.
Okay. The next person is Krishnan. Sharda is saying, can you suggest some combination of technology and alternative medicines, such as homeopathy, Ayurveda, or something? Is there something out there? What are your thoughts on that? Because there's a lot of knowledge in India.
I am not an expert in this area, so I really don't want to misguide the person, but I'm a very strong believer of yoga and meditation. Yeah, I believe it's a great gift India has given to the world. Yeah.
Then the next question is there any country hospital you think that is leveraging technology through innovation better than others? I can answer that for you. It's Narayana Health.
Oh, thanks, Arun. Yeah, you know it from very close. Yeah, thanks.
1 second. I think we should be getting through now, Raghu. This is gentleman Satyaprakash Katuria is saying, thanks, Dr. Shetty. This is so insightful. Seeing so many broken supply chain issues, does a healthcare marketplace make sense within COVID and post-COVID?
Didn't get the second half of the question.
Is there a healthcare marketplace? Like you have Amazon for stuff. Is there a healthcare marketplace?
No, essentially, if somebody wants to innovate something, I prefer more than the marketplace. Our biggest problem is we use more than 10,000, 15,000 different types of materials in the hospital. If somebody can come up with a very, very cheap RFID or the one barcoding or whatever, so that we can, every time we use a product, we can keep a track on that, and a software to tell us exactly how much money we spent at the end of 5 days or 10 days. That will really, really help us, because today, believe me, no hospital knows how much money they spend on doing a heart operation or a brain operation. Everyone comes up with all kinds of figures, but they are not really realistic, because there is no way we can keep a track on what we use over a period of 5 days, 10 days, 20 days.
Okay, I think we should be getting to the last question, Dr. Shetty. I know there are too many questions. The question is, which is back to the pandemic going on. What's your view and thoughts on strengthening the surveillance system for epidemics?
You see, the COVID caught everyone off guard. America was the most prepared country to face all these pandemics. You have seen how the COVID-19 pulled the rug under their feet. So essentially, this is unprecedented. But believe me, next epidemic, now we have become very, very smart. We will be able to address it. The issue is, at the end of like today, when we are talking about even treating the disease, there is no protocol, there is no standards, nobody knows how to treat, whether to treat the virus with the antiviral or whether we treat with steroids. So even the containment strategy or even the tracking system, still we are not very clear. But my suggestion is, virus will remain for few more months or maybe 1 or 2 years. Only way you will be successful now is, first, don't look at India as an amorphous, homogeneous country. Just look at it like Europe. Like the virus, the way the patient will respond, I mean, the virus will be controlled will be dramatically different states. Goa will do well, Karnataka will do well, Kerala will do well. Some states may not do well. But if the state governments plan to give the entire power to the district administration and give them the right power to do as many tests as possible, because if you don't do the test, you are not going to win. Okay, as many tests as possible, then track the patients, the contacts, and quarantine them, then we will win. And long term, this is the only strategy. You can't have a national strategy. Everyone has to concentrate. It is exactly like what Henry Ford once said: there is no big problem, there are thousands of small problems. So if we can break the problem into small problems, you will win.
Thank you, Devi. I think that was really insightful. I'm sure the audience and the participants have really enjoyed this. So over to you, Raghu, and thank you so much, Devi, for all this sites, because I'm pretty sure our audience is just itching to come to Narayana Health and do a collaboration. I have many questions on that. So we need to find a way to get everything to Devi. I'm happy to be involved in that. I mean, me and Devi work together on many innovative stuff, so I'm happy to be the point person for that.
Arun, thank you so much for wonderful moderation. And Dr. Devi Shetty, I've been hearing you face to face on the webinars. It's wonderful delight to you always come out with something new, either by way of an interventions or innovations, or even now today I learned about the greatest challenges what we can face. As you know, NASSCOM has been working on technology platform for quite some time. And soon we are going to launch a mega challenge, innovation challenge across the country. And I think through Arun, I will reach out to you.
Looks like
solutions. And these challenges will be a kind of eye opener for many of the innovators. And thank you very much once again for your wonderful time on this. Okay, let's move on to the next of the sessions.
Thank you.
And
Thank you.
Thank you, sir. We have 4 sessions curated by the people who registered. All the participants have really done a fantastic job of choosing the best topic. And they also voted. Again, 50% of the participants participated in the voting pattern, and they selected 4 top topics to be discussed today. Now, one reminder to all the speakers who are coming next. We have 4 sessions, and each session is for about 15 minutes. And end of it, the session moderator is going to take the presenter through the Q&A sessions. I request all of you to stick to the timelines. And at the end of the session, we are going to have a feedback form. I request all the participants to really take a little bit of time in giving us the feedback, and it really helps us to figure out the best of the sessions in the next sessions, whatever NASSCOM is organizing. Thank you very much. Now I lead to Niranjan. Niranjan is a co-founder, Cyclop MedTech, and he's going to moderate the session, next session. Niranjan, up to you.
Yeah, thank you, Raghu. So I think after this super awesome presentation talk by Dr. Shetty, I'm thrilled to actually moderate the second session, which is actually the first session of the Unconference talk. So happy to introduce Abhishek Shah. He's the CEO of WellThy Therapeutics, a digital therapeutics company which inspires and enables people to prevent, manage, and control their chronic health conditions. Prior to WellThy Therapeutics, Abhishek co-led an early-stage capital fund where he invested, built, and scaled HealthTech ventures in Asia, prior to which he held leadership positions in media conglomerate, a contract research and manufacturing pharmaceutical business, and a medical consumable business. Abhishek holds a Bachelor of Science in Chemical and Biomolecular Engineering from Georgia Institute of Technology and an MBA from Indian School of Business. Very warm welcome, Abhishek. Over to you.
Great, Niranjan. Thank you so much, and thank you, Raghuram, and all the esteemed panelists and keynote speakers. Very inspiring first session from ma'am and from Dr. Shetty. What I'll do is I'll quickly walk you through, the problem statement the way we see it, and I think it's something that everyone can at least think about, which is, when you start thinking of managing healthcare remotely, is really telemedicine enough? And what is managing care remotely? What does it entail? And what actually goes in doing for managing care remotely? And what I'll do is I'll spend a few minutes talking about this, and then happy to take on questions, right? First and foremost, let's go back to first principles. We know that care in COVID has been compromised. Yet at the same time, the needs of the patient have only increased. When you take healthcare and you start splitting it up, it just goes back again to 2 things, right? There's acute care and there is chronic care. Today, COVID sits under acute, and all of us are neck deep in solving for that. And it's incredible to see how the ecosystem is coming together. But there is this other aspect of care, which is chronic care. And we want to see how healthcare or telemedicine is actually, as a subset, is managing all of this, right? And if you're starting to look at all the innovations that are coming online, either they already existed before or they're existing and coming up online now with innovators coming to the forefront, you're seeing a large boost that acute care is going to get from this. And a lot of innovations that are going to innovate for COVID are going to also continue to help acute infectious diseases for some time to come. Whether it is condition diagnosis, it is the treatment and follow-up. And what you're finding is that the role of telemedicine can work very, very well, especially in an environment in which you're not just looking to care for the patient, but at the same time, you're looking to keep the healthcare system safe and the physician safe as well. And needless to say that that is the need of the hour. Teleconsultations, however, do come with a couple of limitations. They allow for the virtual consultation. They allow for audio, video, they allow for payment, they allow for the physician to be in front of the patient, inversely the patient to see the physician and get advice directly from the physician. But when you're looking at the entire infrastructure that primary care, secondary and tertiary care has set up, what you're finding is a lot of pieces of the puzzle don't necessarily come as quickly. The clinical decision support that's necessary for a physician to make the right treatment decision stands compromised. The continual care for the patient, which in any case was missing or primitive at best, continues to be a challenge and especially relevant in certain conditions. Of course, remote patient monitoring, RPM, we've already spoken about this, is come front and center as a need of the hour. And let's not forget at the end of the day that all
I'm
these...
sorry to interrupt, Abhishek, but your screen is not visible. We are all seeing only white screen, unless you have made it intentionally.
No, that's not correct. I'm not sure what's going on.
You have to put it on a slideshow, and maybe you have to switch your screen onto this.
Just a second. Can you see my screen now?
We can see your screen, but I think you have to put it on the slideshow. Yeah.
Tell me if it works.
Yes, we can see it now. Yes, it works.
So I don't know if you saw any of these slides, but let me. Did you see any slides except for the first slide?
No, we didn't.
Okay, great.
We are seeing the slides for the first time, Abhishek.
Okay.
So
Sure. Going ahead. So essentially, where I was saying was acute can see a lot of value that comes from teleconsultations, but teleconsultations themselves come with limitations. And like I said, remote patient monitoring remains a need of the hour. Building doctor experiences that actually work for the physician, work for the HCP, work for the paramedicals remains an important piece, because doctor fatigue is a very critical part of this. And teleconsultation fails to solve for certain aspects of care, as we're imagining a world not just in COVID, but we're imagining a world post-COVID. And again, as Dr. Shetty mentioned, right, if we're innovating for a world that goes beyond COVID, it's important to recognize what the role of digital health is in that. That role, when you're seeing, actually has a very big component of chronic disease management in it. Today, the largest amount of deaths in this country still are attributable to chronic diseases. You have a very large burden of healthcare, which is incredibly, I mean, it's unfathomable the amount of burden that chronic disease is facing in this country. And it just so happens that the COVID-19 risk factor is a lot more for these patients. So how can healthcare actually solve for it? How can telemedicine solve for it? When you're looking at this largest burden of healthcare, which actually leads to a lot of hospitalizations, it leads to a lot of ICU bed sort of utilization, and obviously a lot of deaths, and normal chronic disease management stands compromised. You're seeing that teleconsultations can solve for episodic care, but not necessarily for continual care. When you're seeing an opportunity for an episodic visit to happen, and that episodic visit now can be solved through telemedicine, one big thing to consider is, what about that time in between? What about the clinical decision support that the physician needs? What about the support that a patient needs for monitoring their vitals, for behavior change, for improving their self-management, for answering their questions, their medical questions, their FAQs, for building habits? All that support today is still a big piece of the puzzle that needs to be solved for. And you're seeing that teleconsultation can get some of the way there, but definitely not all of the way there. And when you flip it and you look at the doctor burden for chronic care delivery is absolutely immense. In COVID, it's even more amplified. The infrastructure is clearly shown to be wanting. There is only X amount of time that a physician can spend on a consultation. And during that time, a physician, which anyway was compromised with the amount of information that he had to treat the patient, now has even less, and has even less bandwidth. And the ability to influence the patient outside of the four walls of the clinic or outside of the teleconsult still remains really poor. And as a result of which, you're seeing poor adherence to protocols. And that is not just resulting in suboptimal care, but it is resulting in that the threshold that hospitals and the healthcare system need to manage going up. So where we came from was, can we actually look at a solution? What's out there that has already proven to work? And I'm looking to have this conversation about what's beyond teleconsultation. there is this area called digital therapeutics, which have been prominently being utilized in the West for some time, where they're evidence-based therapeutic interventions. They're driven by very high quality software programs. They are used to prevent, manage, or treat a medical condition, and are used as an augmentation to the standard of care. And the most important thing is they are built on the back of clinical evidence, and they have the real world outcomes to prove that they work. And what we found is, as we've started looking at this world of clinical outcomes, patient outcomes, doctor satisfaction, and overall affordability in care, what you're seeing is that there are clinically proven algorithms and protocols which can establish real world outcomes and safety and efficacy for patients that can play a role in this new paradigm shift that we call a post-COVID environment. And that paradigm shift is extremely critical because you can actually improve the quality of life. You can actually reduce cost of care. Each and every digital therapeutic has a ton of elements in it, which are basically the same. There's always going to be a user interface for patients. There's always going to be something for the family member or for a accountability buddy. There's always clinical decision support for the physician. There's always monitoring and intervention dashboards for remote patient monitoring, remote patient interventions. There are connected devices integrated into this for monitoring patients better. And there's an entire slew of clinical intelligence algorithms that are advising and moving and nudging the different stakeholders in a regulatory compliant manner. But what's equally interesting is that it is built on proven medical guidelines. It has reimagined those guidelines to be delivered through a smartphone. And it has the combination of clinical intelligence, behavioral intelligence algorithms, and all of that is seamlessly working together to augment patient outcomes, because now you're taking every stakeholder. It could be the payer, the provider, the entire ecosystem, the patient at the center, playing a better role in their care, and self-management, and the family member or the accountability buddies. And all of them can play a much larger role in improving health outcomes, because part of de-stressing the healthcare ecosystem is empowering the patient to do more and do it in a safe manner. And that's where we're seeing that when you combine all these things that have already happened and have already proven within remote patient monitoring, within digital therapeutics, and all the very best that telemedicine and teleconsultation have to offer, you have a lot more pieces of the puzzle being solved for. Is it the perfect answer, and will healthcare always have near perfect patient outcomes? Absolutely not. But you can get a meaningful step forward. And as Dr. Shetty mentioned, it can exist even beyond a COVID environment, because it is a perfect storm to get these innovations out to market, but it can last and make a meaningful difference. And that meaningful difference has to continuously be shown with evidence. If it is type 2 diabetes, hypertension, dyslipidemia, heart failure, asthma, oncology, doesn't matter. What all these solutions offer is the absolute truth through data. And through that data, as long as these solutions are able to show clinically significant improvement in outcomes, great safety patient profiles, lesser adverse events, lower cost of healthcare, better quality of life for the patient, and better clinical decision support, and better and lesser fatigue for the healthcare professionals, then these are the kind of innovations that should be inspired and enabled to be able to thrive in this larger ecosystem. Because with that, what you're finding is innovations like this, when combined together, can actually solve for all of the patient, not just one condition, but multi-morbidity, for all their time, not just the time they're in the clinic or at the time of the consultation, but all the time that they're actually suffering from this chronic condition. And by doing that, you're actually having lesser burden on existing stakeholders in healthcare, while increasing the value on healthcare, while increasing all the value creation of all the ecosystem partners that come with, and at the center, bringing the one person that actually matters, which is the patient. What you're able to do for the physician is get vitals, biochemical parameters, and all sorts of remote patient monitoring and other parameters, moods, medication adherence. You're able to build algorithms for escalations and alerts, which really can empower a doctor with data, with decision support, with analytics, and really help a doctor in a safe manner to do more for his or her patients, while at the same time making sure that they continue to thrive in the practice in their workflow that they're used to. And last but not least, we genuinely believe that technologies like this, teleconsultation, remote patient monitoring, digital therapeutics, digital care in general, can lower the healthcare system burden, can bring better safety to both patients and HCP, make sure that the capacity to serve IPD patients is not compromised because you're maintaining and improving chronic
Sorry,
patient
you have
outcomes,
20 seconds more.
and remotely monitor and escalate only those that matter. That's it from my end. I thought to share this, and then happy to answer any questions.
Yeah, so fantastic, Abhishek. I think you made a very compelling argument for digital therapeutics. And I think in the current COVID scenario, anything over and above, anything to help our already stressed infrastructure is definitely going to be a welcome measure. And I'm sure everybody is going to appreciate that. So let's take up a few questions. There are already plenty of questions. The first one is from Vikram Rai. He asks, with COVID-19 effect, there seems to be clear realization at the customer level that clinical point of contact comes with infection risk. Do you believe that there will be more pull by customers beyond cities as well to consume digital therapeutics?
I think what COVID-19 has brought to the table is a realization in everyone's mind that healthcare needs to be a higher priority than they thought so. And I think that fundamental construct is allowing for a pull from the customer to ask for better quality of care, to get safe care, or to even access care for the first time or look at healthcare very differently. So yes, we believe that there is a pull, but I don't think it's just limited to digital therapeutics. I think it's limited to anything and everything which is great quality care at the doorstep that the customer is in today. And the risk of infection will go away, but the demand for great quality care will not. And that demand is going to allow a spur of innovation, which hopefully is going to take healthcare to the next level.
Okay, thanks for that. And another one by Aarti. What's your opinion on collaborative and participatory health?
Healthcare is not one actor's job, right? And anything anything else would be foolish to say. So absolutely, that's the only way forward. But it needs to be somebody needs to own the outcome, right? At the end of the day, you can't have 5 actors and every actor saying I've done my bit, and nobody's owning. At the end of participatory health, the only metric that matters is better patient outcomes at an affordable cost at the time at which it's needed. So as long as there is an owner to the entire spectrum, and there's the equal amount of onus, therefore, for every actor to contribute, collaboration and participatory health is the right way to go.
Thank you. Here's one by Manish Sinha. What about facial expression monitoring? Do you think that will be helpful in digital therapeutics?
Absolutely. You're finding that when you start looking at patients' moods, patients' stress levels, patients' mental health, it's so powerful. And whether it's chronic or it's acute, mental health is a critical part of patient management. And as you're able to get more biomarkers to understand more about a patient's mental health, it could be their pulse rate, it could be their facial expression, it could be their their breath and analysis on breath from where you're getting mental health vitals. All of these things are super critical as you're looking at it. Mental health is just one use case. I'm sure there are many more.
I think we'll just take the last 2 questions. A very relevant question from Nidhi Kapoor from an Indian context. How digital therapeutics applies to rural area which are not that close to technology as compared to urban populations?
So the great part about digital therapeutics, and one of its biggest vices, is that it needs even a smartphone is good enough to be able to get there. Does that mean that you're solving for all of rural India? No. But at the same time, what this allows is accountability. So when digital therapeutics is accountable for outcomes, shows outcomes, and in a lot of environments, actually there's pay for performance on outcomes, there's a huge win. So there is a limitation on the smartphone, but as smartphones go through, rural India and all of India stands to benefit, because language is taken care of, multilingual is taken care of, visual intuitive interfaces are taken care of, and the patient can get access to world-class care without necessarily having to go to a city to get it. So I think it's extremely beneficial, with the one limitation that data and smartphones need to get to that particular customer.
Okay, I'll just take one last question from Shobik Sanyal. So does telemedicine, okay, what about critical care through telemedicine and through digital therapeutics?
There are use cases, absolutely, but it's not a substitute. I mean, there's a reason why critical care requires very, very close monitoring of between the machinery or the respective paramedicals or the physician. So I think there having digital therapeutics play an augmentation absolutely makes sense, but it is part of the care continuum. You cannot do without the normal critical care components. Again, I'm being very broad. There are specific use cases where there is more and less, but critical care is an element that still requires face to face to a large extent and on site.
Okay, thank you so much, Abhishek. For remaining questions, Abhishek's Twitter handle is ABHINSHAH. I repeat, it's ABHINSHAH. We'll also put this in the chat window. So please do tag him. He can respond to the remaining questions. Once again, thanks for a wonderful session. I hand it back to Raghuram.
Thank you.
Thank you, Niranjan. Thank you for wonderful moderation. Abhishek, it's great to hear you, digital therapeutics. And we also hear a lot of gamification entering into digital therapeutics combined and making a little bit of inroads into the care protocols and care therapy. We'll definitely be in touch with you for a little more intense sessions for our audience, specialized sessions, webinars. Okay. And for the benefit, thank you so much, Abhishek, for joining. And for the benefit of the viewers, audience, the Twitter handles are very active. I request all of you to go to Twitter. Our handles are hashtag India Productified and LHIF. It's there on the communication what we have sent. And this will be useful. The Twitter handles of the speakers are also very active, and you may like to ask your questions there. And thank you very much once again. Let's move on to the next session. The next session is from Mr. Agendra Kumar, President ESRI India, and to take us through the process, I request Ganesh Chandrasekharan, consultant from Samsung Research Institute. Over to you, Ganesh.
Yeah. Thank you, Raghu, and thank you, Niranjan. So after Dr. Devi Shetty's interesting presentation and also a session by Mr. Abhishek, I would like to introduce our next speaker, who is Mr. Agendra Kumar. He is the president of ESRI India, a provider of geospatial technology. Mr. Agendra Kumar has over 30 years of experience in the IT industry and in the past has held senior leadership roles in several multinationals such as Digital Equipment, Silicon Graphics, Veritas Software, and Symantec. He's also the Senior Vice President of the Association of Geospatial Industries. Over to you, Mr. Agendra Kumar, and the screen is all yours.
Thank you, Ganesh. Am I audible?
Yes.
Okay, good. So thank you for inviting me to speak in this session. And also we had a talk by Rekha and Dr. Devi Shetty in the morning. It's been a very enlightening sessions so far. A lot of good information. In my short talk, I'm going to speak about GIS, Geographical Information System, as a technology and how it is helping us in fighting COVID-19 pandemic. Before I get into in my presentation as such, I have a bunch of slides. So before I do that, I just want to spend a couple of minutes in explaining what GIS means. So a geographical information system is a framework for gathering, managing, and analyzing geo-referenced data. So is the important term here, and what it means is that anything that has a latitude and longitude. So that's what GIS comes into picture. It organizes layers of information into visualizations using maps. So in very simple terms, we all use Google Map. So that's a kind of consumer GIS system, because it has information about road networks, about various buildings, about traffic patterns. So these are individual layers. So there's a layer of road network, a layer of traffic, there's a layer of points of interest. So it's a mini GIS system which we use as an individual. But when you look at organizations, it's an enterprise GIS technology that plays a role. And so that provides lot. It has many more layers. People can customize layers. People can populate their own data on a GIS system. So GIS as a technology deals with location information. So it helps in mapping, like when we apply it to COVID-19, it helps in mapping COVID-19 positive cases, health facilities, tracking the movement of people over a period of time, and especially if they're in quarantine, they're still moving around. This is done through integration of mobile data. So there are other technologies which can be integrated along with GIS. And GIS can help in analytics of finding trends under pandemic situation, kind of situation that we have right now. For example, relation of factors like age with other demographic information with COVID-19 positive cases. And all this data is presented on maps, and analytics are presented in form of dashboards. So I will, are my slides visible?
Yes.
Okay. So let me move to the next slide. And this is about understanding and responding to COVID-19. So there are 5 stages that we've classified. So first of all, you map the cases. Wherever you find a positive case, you capture the location and you bring that on a map. Then once you have many such points of positive cases, then you sort of start seeing some trends that how the pandemic is spreading, in which area it is moving. So you sort of start mapping the spread, direction, district, how's it going. And then you look at vulnerable populations, people in areas where there are people with old age, or there are people who are not educated, or people small dwelling units where the density of population is very high. So you start mapping those things. It's just to be prepared. And then you map your capacity, that how many hospitals I have, how many beds I have, how many ICU beds I have, and things like that. And then you communicate through maps with each other within the government setup. Next stage comes about modeling and spread of impact, spread and impact of disease. So here what happens is we try to understand the communal risk, that how it can spread, which are the densely populated area, and whatever actions we are taking, we try to measure the effectiveness of those actions. Like we did a lockdown in the country, what was the impact of that? If we create a containment zone, what's the impact of that? Then you manage the resources. Like in some areas, you may require more ventilators and things like that. Then you move them about, and then you look at different site selections for, say, setting up quarantine centers and things, isolation centers. And then you start communicating with public. You keep giving information to public. So on a map, you know different areas, so you can give areas alerts to people. So that's what technology brings. So basically, GIS provides an integrated system for management of COVID-19. So it's not only COVID-19. This technology has been used in the past also for situations like when we were dealing with Ebola or Zika, or things like polio eradication all over the world, or tackling malaria instances. So it's a technology which is not specific for COVID. It can be used in many other situations. So basically what happens is it helps you in mapping various things that I mentioned, getting the data on a map so that you can visually see the information. And then you create dashboards which give you picture at a glance, and those dashboards can also be used by government authorities to make decisions. And once you have a lot of data coming in, you start running analytics, that how the disease is spreading, the trends, and I'll show you some examples of that. And then you bring data science into it. You get MI, AI, ML, you get big data analytics into that. And then we also have mobile devices which can be used for creating the data, collecting the data about positive cases and things like that. and all the how many people are there in which quarantine center, so that kind of information can be captured. So this is an example of a dashboard which was created by NDMA early in March. Around 10th of March, this dashboard was launched, and this is a snapshot here, but I will take you to the online picture of this. I'm sorry, I think I've closed that one. Yeah, here it is. So this is the online picture. So this is the latest data. Is the data updated on May 1. They update it a couple of times every day. So you see the latest on the left side. You see the latest confirmed cases. You see the trend that how many cases are coming total. What's the cumulative cases every day? And if you come on the right side, then you see statewide data, that each state has how many. If I click on confirm, then you see daily statistics of how many confirmed cases came every day. So as you move the cursor, you get to see the information about every day. And the next step provides the information about recovered cases. And the last step provides the cases where we unfortunately lost some people. So this is basically one of the dashboard which NDMA has. This dashboard is in public domain. There are a lot of other analytics they are doing which is not in public domain, which is being used internally by government for taking certain decisions. Then we move down to the next slide in my presentation, which is another example from Tamil Nadu, where they have classified red, orange, and green areas. Now we are all hearing that governments are classifying areas into red, orange, and green, so that they can decide where to exit first and where to take more actions before we can exit. And here also they have a graphical representation of positive cases, active cases, and discharge cases. So that's their way of looking at the information for decisions by the Health and Family Welfare Department. Here's something which is created by Punjab government, and this is also a similar map which gives them information about each district, how many cases are there. The bigger the circle, more are the cases. And then at the bottom part, they also have a representation in form of a bar chart, that how many cases are there in which district, so that they know where to focus more, which districts have less cases, and where activities can start first. Another example about Jharkhand state, they also created a similar dashboard, and they are looking at how the pandemic situation is changing. So they're looking at various districts, the number of quarantine centers, and how many people are in quarantines. So all that information is available here. So these are some of the examples of the usage where GIS has been used by various state governments. And then in Bangalore, there's a slightly larger initiative they took. They created a war room where Chief Minister himself periodically comes and looks at the situation on a map. So here's a map which gives them district and city-wise information about COVID-19 cases, and they can run different kind of analytics and different what's going on in different districts, and what are the resources available, and how the district authorities are able to tackle the situation. So it's a much larger screen, so that's a difference, and a lot of real-time data which gets captured in different districts that comes on in this war room, and the government is focusing about making decisions that how to contain the spread of coronavirus. And that brings me to my last slide, where so far we have seen we have come in a journey of containing COVID-19 at a certain level. We have been in the condition of lockdown for about 40 days now, close to 40 days. The plans are to exit from this, so GIS can help in exit and further management of the disease as well. So this technology has helped us in contact tracing and tracking. It's possible to track people's movement when they don't adhere to the quarantine guidelines and they move around. That happens by integrating mobile data with the GIS maps, so that we can know up to what distance they are moving around, and that will help controlling the spread and bringing it under control, and management of red, orange, and green zones. So these are dynamic dashboards. So as some of the zones come out of red and orange, from red to orange, orange to green, those get updated periodically on the maps and decisions can be taken. For long-term management of disease, because there could be cases coming up after a few months also. So where they are occurring, what steps to take, how to contain the spread, GIS will play an important role there. And also when the administration of vaccine starts, it will be a mammoth exercise to give vaccination to everyone. So like it was done when polio was eradicated, every individual case of polio was mapped. I think a stage will come when we will have to map every place where vaccine has been administered and where it is yet to be administered, so that the entire population gets covered. So I think GIS can play a very effective role in all these segments. That's all that I had. Thank you. And I'll be happy to take any questions.
Yeah.
Thank you.
Thank you for your presentation, Dr. Mr. Agendra Kumar. So there are a few questions related to the area in which you just spoke about. It's about Mr. Hemant Jain has asked a question about the accuracy and the confidence level you are able to achieve by this solution. And the second part of the question is if patient-specific app having GIS interfaces influence, then how GIS can detect accuracy?
Okay, so see, most of the mobile phones today, given the technology that we have, they can capture the data with about 15 meters accuracy. Okay, so to that extent, the location can be accurately captured. Now, if we have a mobile app where you have a GIS interface along with other features, and there are many states who are using such apps, and Punjab is using, Rajasthan is using, and they have been using it very, very successfully. In fact, apart from that, in Bombay, MCGM is using a couple of mobile apps. They have app for their own MCGM staff, for the municipal staff, and also for citizens. So in these apps, the one big thing which is being done today is to provide the information to people. Secondly, if you look at Arogya Setu app today, it does not seem to have, to my knowledge, it does not have a GIS interface as well. But if we have a GIS interface on Arogya Setu app, then it will be, today we look at Bluetooth, there's a person close by, but once we have a GIS interface, the location of that person will be visible on a map, not only to the person, but also to authorities. And the movement will also be visible through a map to the authorities. You don't want to give the movement to every public, but authorities will have the advantage of looking at the movement of infected people or the people who need to be watched, because they are suspected cases where they have had exposure to someone and they need to be tracked. So I think GIS interface will help in doing those things very effectively.
Yeah, there are a couple of questions in similar lines, which is from Aishwarya Shwed, where they're asking that can GIS be used to monitor the compliance of lockdown, and can GIS be used beyond the pandemic?
Yes, so GIS, there are two questions in this. One is that can it be to track the movement? Yes, it can be used to track the movement of people who are not adhering to lockdown and they are moving about. So that is possible by integrating the mobile data along with GIS. And the second question was whether it can be used for after the COVID gets over. Yes, of course. GIS used for health applications in the past also, and it's a technology which is not limited to health sector alone. GIS has been very effectively used in many other disaster situations like floods or cyclones or earthquakes. And it's like a horizontal technology. It's used in mapping. It's used by utilities. It's used by telecom companies. It's used by water resources, water distribution. So it's used in many areas. In health sector also going forward, I think states can use GIS technology to ensure that they have enough resources in their state like enough hospitals, looking at the population, how many hospitals are required, how many beds are required, what are the other health facilities available. So sort of it's sort of a GIS system, which will help in managing such situations in the past in a much better manner.
Yeah, one last question, and I think before we end the session, it is related to how GIS can be used for forecasting the transmission rate of COVID, and this is from Neelam.
Okay, right. So what happens here is that see, when we look at forecasting the transmission rate, it's become a little complex. We have to bring in the machine learning concepts here. It is being done in certain areas in our country also. So basically, we start looking at trends, and now now that we are in about almost 2 months into COVID-19, we have some data, and we have good number of cases. We have about 7 lakh plus tests which have been done in the country. So we have some trends available that in which area, if you do this many tests, you get this many positives. So I think that data is being used to create some trends and forecasts.
So thank you, Mr. Agendra Kumar. It was a wonderful presentation, and I think a lot of insights have come in and which would benefit the viewers. And I think there'll be quite a few questions which you can take it offline. Thank you.
Thank you so much. Thank you.
Thank you, Ganesh, for wonderful moderation. Agendra, I think almost like 5 to 10% of the innovations across after the COVID pandemic, which just got exploded, all around about tracking and tracing, and your insights are very, very useful. I think we'll have a long way to really explore the possibilities of GIS, for not be just for the COVID part of it, but for even general healthcare. Now, let's move on. Thank you very much for your time. If you, all of you, the listeners, viewers, if you are looking into your chat windows, some of the handles, Twitter handles are being posted by our moderators. Please go on to NASSCOM product handle, NASSCOM COE IoT handle, and also hashtag LHIF and hashtag India Product 5. These are some of the good channels for you to ask the questions, give your feedback. It will be useful for us. Moving on to the next session, we have seen a huge spike in medtech innovations and very frugal innovations, and also some people call it Jugaadified. So most of these innovations coming in the last 1 or 2 months have started the market, very useful, and they are fragmented. Now we have Mr. Nitesh Jangir from Coeo Labs talking about the role of India medical technology innovations to fight the COVID at global scale, not just in India. And to moderate the session, we have Vibhav Bansal, Software Products Vertical Lead from NASSCOM. Over to you, Vibhav.
Thank you, Raghu. Thanks a lot. This has been a quite interesting session since morning. First, Devi Shetty, then Abhishek, and Agendra talking about variety of stuff, and Dr. Devi Shetty was, of course, no doubt, was brilliant. And guys, next we have Nitesh Jangir. Nitesh Jangir is founder and director of Coeo Labs. He was featured as 30 under 30 in Forbes for Asia Pacific in health tech space last year. Coeo Labs has also been featured in NASSCOM's Emerge 50 Awards and Deep Tech Club. I will not take much of a time here. I will leave it to I'll leave it to Nitesh. And Nitesh, the topic is very interesting, and everybody would be interested. How can we utilize this Indian medtech innovation at global scale? Over to you. Would appreciate if you could, switch on your camera and your internet bandwidth allows. Thank you. Over to you, Nitesh.
Hi, we both having some internet issues, so webcam may not work properly. But thank you, whole NASSCOM team, Mr. Batra, Mr. Seth, Vibhor and everyone for inviting me. And I'm here. I'm going to talk about an interesting segment of healthcare, medtech innovations, or overall medtech industry, which are largely neglected by overall both government as well as by investors or everyone. And COVID brought it into attention of everyone, that how important this medtech industry is. Just before I talk next, I would like to you guys are able to see my screen?
Yes, we can.
Yeah. So just some key stats about Indian medical device industry. If you see, in India, 70% of our patient population can't afford healthcare services in private care settings. And even if people can afford, especially a critical care or any super specialty care, they can afford it only with really high, significant financial stress. Most of care is actually being delivered by private sectors, but the single entity which deliver the most amount of care is still a government. So one of the key aspect of overall healthcare delivery is medical devices. The way we have progressed a lot in drugs and biotech industry, and then we are becoming supplier of whole world, as you are seeing, even with the hydrochloroquine and other drugs India is supplying. This is a total opposite case in India in terms of medical devices. We import 75% of medical devices, and I'm not talking about complex medical devices like CT scan machine. Now you might be hearing is things like mask, essential PPEs, or even normal suction tubings. Everything we are importing here. Most of these innovations are not designed for low resource settings. And even our Indian manufacturers, they are not even 60% of them don't sell in India. They are exporting these innovations. So the idea is that right now, or even India is in a huge need of having, as Dr. Devi shared, affordable, accessible innovations, which can be adapted to our setting and really useful here. So one of the question we had around 4 years back, that why we are still relying on devices which are not made in India, and what's so complex about medical device innovation that we are not doing it a lot. So one of the key issue what we realized through our research is why we are not innovating a lot in medical technology sector or hardcore medical devices side is it's truly interdisciplinary. The way Dr. Shetty talked that many times we engineers, we sit in our rooms or sit in our labs and think that doctors might need this solution, or a hospital might need this solution, or even a patient might need this solution, and then we developed it, and then we go and there is a lot of PR about, and then but ultimately none of these reaches to the hospitals, and hospitals or doctors do not buy it because of XYZ reasons. So, and the way our system has been designed, I know I'm an engineer and I am not trained to work with I'm electronics engineer, I'm not trained to work with a mechanical engineer. So working with doctors, working with social activists, working with nurses, working with hospital administration, their management in this whole multiple stakeholder environment, and then creating a solution which fulfills everyone's need is really a critical aspect of medical device design. And somehow we have not been trained into this segment. Other thing, because this here when especially from last 2-3 months we are seeing a lot of innovations are coming, but the medical device innovation or medtech innovations are at cutting edge in terms of not just by the design or technology which they are using, but also the kind of testing they go through, because it's about somebody's life. We are seeing many ventilators are popping up, many things are popping out, but then through my work, I keep on talking to doctors, I keep on talking to someone like Dr. Devi Shetty or his ICU team or other ICU teams, and all of them say that we are not going to use these solutions because according to them, these are not tested well. These are not the means people have seen designs on website and they are just designing it. They never even come to a doctor and ask that whether this is the solution which is going to work for this specific disease condition. So and then many of these solutions are not been tested. Dr. Devi Shetty also said, especially in this kind of scenario, we need solutions which are tested well and already validated that they can work without any intervention or without any failure, because we don't have resources to handle these failures, and there is no excuse for these failures. These failures can be really fatal in scenario like COVID or in any critical care scenario. Other really important aspect of overall healthcare or medical device innovation is clinical trials. Again, many of the devices, many of these solutions require clinical trials that adds lot of time. And overall, a medical device innovation cycle in usual time from idea to a commercialization product takes somewhere around three and a half years, and that involves around one and a half year of hardcore clinical testing. So there is no stone turns around that by any mistake or by that we don't know aspect of medical device which is not safe for the as any specific group of patient. That's why clinical testing becomes really important. It adds time as well as money. And one segment which is coming up a lot in India, and we are very few people have good understanding, which is overall regulatory aspect in India. It's coming up. Government has said that by 2020, by end of 2020, we should have all medical devices regulated in India. The good thing that our medical device standards are mostly harmonized with the most developed country, as well as if we follow them, our solution would be harmonized with the more and more developing countries which are getting their own regulatory framework. So having a regulatory framework is really good. It's opposite to what most people usually get afraid of, that regulatory is something which we should not go. But then being someone who is in
Hello, Nitesh. It looks like we're losing you. Raghu, you're on mute. I think you're trying to say something which is on mute.
And I'm just seeing, is this from the speaker? The back? No?
That's Nitesh. Nitesh, we are not able to hear you. If you're listening, you may please check it out. Looks like his screen frozen and he's trying to restart or he's trying to fix this system. Meanwhile, I have a small request for all the attendees by the time Nitesh comes in and my colleagues connects with him and bring him online. Rekha, what do you think? Like Nitesh was talking about, this medtech regulatory approvals are going. Indian ecosystem is very opt for the globally scale development as well, because our regulatories are very far harmonized with the developed economies. I think this is a very good sign and a positive impact for Indian entrepreneurs to build medtech out of India.
Very much true, Vibho. The recent developments, at least last 2 months, we have seen 2-3 things which have happened. One is the speed at which the regulatory has given approvals for the clinical trials. So every day, either for a vaccine or a medicine development clinical trial or a testing kit. That's very heartening. So this pace at which they have been approaching this application. That will be a very good sign for us to in the next few years. Second is also about classification of the devices. That also is going to be very useful because most of the medical devices are still not really fitting into the 23, which got expanded to a little more a number of items. Now, with a specific Medical Devices Regulation Act under the Drugs and Cosmetics Act, it's very welcoming for most of the entrepreneur to really look at the medical devices plus AI-based solutions to improve faster. Having said that, we still have a few regulatory challenges with respect to various other regulatory bodies like BIS coming and trying to approve the medical. I think there is a lot of work happening between ICMR, BIS, and the CDSCO to provide a good speed, and the government is also realized the need for it, and a special committee has been constituted, and NASSCOM is actively working along with that body to speed up this process. Thank you. Nitesh, are you?
Thank you. It looks like Nitesh is back, so let's hear it from him if he's back and able to present. We have I think few minutes left, so we can still have if he's available.
4 minutes. Yeah.
Yeah. So
Nitesh,
Nihal, sorry,
if you want, I can run your slides from my side.
Yeah, that would be useful. Can you? Yeah.
You have to guide me which slide should I go to.
Yeah, just go to the clinical trials one.
Yeah, thank you. Here you go. Can you see this?
So
Yes,
just 4 more minutes before the session changes, including the Q&A. I request you to speed up.
Yeah, I think we should get with the Nitesh's slide, and we may have to skip the Q&A. Folks can connect with him on Twitter as well. I'll share details. Let's see how if we can cover it in the next 5 minutes.
Perfect, Vibhor. Thank you. Sorry for this technical issue. Yeah. So I was at the regulatory side. So in India right now, most devices are not regulated. It's both good and bad thing. Good thing is that these are not regulated, so quickly you can test your solution, validate it, follow international guidelines, and take it to the patient. But bad thing is that most doctors and hospitals want some kind of approval or a validation that your product works. That's why regulatory approval is really needed. But my advice would be right now, people who are making quick solutions specifically for critical care, test it well. Test with the third-party NABL certified lab. There are international standards already available. Make sure your solution meets those requirements, and then only go and touch the hospital or patients. You can this next slide. Yeah. The overall process of medical device development, if you go through all the proper route, proper testing, and the design, development, manufacturing cost a lot. And then we are seeing even at the investor community as well as overall industry is not much upcoming for the medical investment in medical devices. So it's not just because it consumes money, it consumes time, and then still it has a lot of uncertainty, especially with the domestic market. So that this is one of the biggest challenge we are seeing in the industry. We go next slide. So the designing medical devices for India is, again, it's quite different than if you are designing a medical device for any other developed country, because our out-of-pocket expenditure is really high. Our market is really driven by the doctors instead of the system itself. For example, if I'm designing a solution in US, I'm validating it through a clinical trial, and through that clinical trial, if my results have been coming out really well as compared to existing treatment arm or an existing solution, most hospitals will automatically adopt it. But that's not the case in India. We still need to look after many other stakeholders to make sure that these products get adopted. Our healthcare system, especially public healthcare system, is dependent on the state, and it varies a lot with the state to state, which you might see a huge difference from Kerala to UP. And our overall healthcare system is more treatment oriented. So what we are seeing now is that solutions which are preventive or technology which are more into preventive side are not getting adopted really well. People are focusing more and more on treatment. You go next slide. So this was the question. Everyone, all of us wants to solve medical problem. All of us wants to say help people, but then there are so many problems. Still, we get this question that why should we innovate new medical devices? You can next slide. Yeah. You can skip to the next slide. Yeah. So the overall why we can advise right now and what's happening really in the overall healthcare industry because of COVID. A lot of need is coming for medical devices. A lot of solutions are coming up, but then many of these solutions are not going through the process of medical device design and development. Actually, there is a huge need of a process in the regulated industry, which makes sure that whatever comes out of overall design, research and development, as well as manufacturing process is safe and effective, and does meet the criteria defined by the clinical societies or by the international standards. That's where we need a medical device design process. Go next. So one of the most important aspects, and especially looking at the current scenarios, is the testing of the solution, which are coming up. We are seeing a lot of ambu bag based ventilators. Ventilators are coming up. We are seeing a lot of PPEs are coming up, and we are constantly getting reports that these devices are not working properly. PPEs are getting failed. The diagnostic devices which we are getting are not diagnosing properly. The main reason behind it that these are not validated and tested as per the quality defined by the clinicians as well as the standards they have to meet. So the concept validation as well as the overall product validation plays really important role in medical device industry. This is not something which we are making for consumer devices. This is really serious industry and require a lot more attention on the testing, validation, and quality of the product which is coming out of your design process. So we can skip this. Again, you can skip. So the product requirements for everyone who is working in healthcare and medical device development or wants to design solutions. For most medical products, there are international standards available. Even if we don't have Indian standard, I urge you to go through those international standards of quality and then make sure that your solutions meet those quality standards. Either those are solution related to biocompatibility, and other those standards are related to your oxygenation, gas. Even there are standards related to EMR. Even standards are related to AI. So almost for most medical devices, there are standards available. Please go through them. You can. I understand many of these standards are expensive to buy. Please connect with me. I have a way where we can get it free of cost or even at a really low cost. Many of these standards are available at BIS at few hundred rupees.
Yeah. Okay.
Yeah. Can we skip? Can we go to the next one? And again, skip this one. Yeah. So yeah.
Nitesh,
again, we can skip. Yeah. So we can skip this part also. Not. Yeah. Just so overall, many of you guys who wants to invent new medical devices or especially wants to solve healthcare problem, because initial cost of research and development in this industry is really high. Government is helping a lot. Department of Biotechnology, Department of Science and Technology, Technology Development Board have, and many other organizations have research grants available. If you have a compelling need, if you have a solution which can solve a big problem, especially focusing in India. So there are organizations which can fund you, support you in terms of grant as well as in terms of equity funding. So I have listed down few, but then if you can connect with me, I'll connect you with more. So, so these are again few more organizations like BMGF. Some of these devices I have mentioned, I don't have much of time left, but these are many innovations which are in India, which are not serving just patients in India, but they are going globally. Because one biggest advantage being in India, innovating for India, because we are innovating for low resource settings. Whatever we develop here can easily be replicated in most other countries. Those are developed, or those are developing countries. There are solutions like Porus, there are Agua ventilator, Maxio, one of our device, WebCare. It's recently got installed at Harvard Medical School to treat patients, COVID patients over there. So whatever we innovate here, and if we follow the international guidelines and standards to design development as well as manufacture, there's a huge potential we are seeing across the globe. Because especially in the developing countries, the more and more developed nations are closing their doors to export equipments to developing countries, and it can become a big opportunity for India. We are working very closely with governments in Ghana and other places where no country is supplying basic medical equipment to them, and then they are looking after countries like India the way they are looking after India as a drug. They are also looking after India to supply even these medical equipment. And if we can supply them, this is a good opportunity for us, both which can help us not just our economy, but also it can help overall humanity.
Thank you,
thank you all.
Nitesh. I think this is quite motivating and interesting for people to know that how can we leverage Indian environment to motivate and scale at the at the global level. Unfortunately, we do not have enough time to take audience question, and I will encourage folks in the audience to put up questions for Nitesh on the Twitter, and he will respond to them. He has promised us. I have shared those details, the hashtags, etc., that you can utilize to ask questions for Nitesh. Over to you, Raghu, for the next session. Thank you.
Yeah, thank you, Nitesh. Thank you, Vibha, for a wonderful moderation. Nitesh, you have done a fantastic job in compiling all the possible information which is required for the Indian innovators in the medical devices. And I hope many of you will be reaching out. And definitely, you're going to bridge the gap between the Indian innovation and international markets. Thank you so much. So the visitors, listeners and viewers on this webinar, we started the day after the opening address by Ms. Rekha Menon, a fantastic address by Dr. Devi Shetty. And we also want to end it on a great note with an address by another doctor. So we have with us Dr. Aravind Kasargod. He's the Director of Medical Services Cloudnine. And he's not just a doctor, practicing doctor, a pediatrician. He's also an MBA. And it's quite surprising that he is done in the medical, economics. And he's also a person who implemented a lot of technology wherever he visited. And he's a keen user of technology for his own personal use, and also a healthcare entrepreneur. Over to you, Dr. Aravind, for a wonderful session, which I'm going to really looking forward to listen to you. And I will take the questions and answers at the end of the session. Thank you, Doctor.
Hey, thanks, Raghu, and it's a absolutely pleasure to be with the NASSCOM team. You're one of my favorite teams, as you know it. I've been associated with you for a while. First of all, I think the talks have been fabulous, starting from Devi's talk all the way down to the last speaker, who have addressed a lot of things that I'm probably going to say. One thing I would request, Raghu, is I usually don't talk my talks with the last slide. Can I go to my first slide? Thank you. Anyway, so The topic, of course, is reapplying the minds for quick adoption. So let's go to the next slide. What does reapplying adoption mean? Adoption, is there a slide before this? Okay, just go ahead, no problem. Next slide. So adoption means the action of fact of choosing to take up or follow the use of something. So basically, you're going to use something. And what does reapplying mean? Next slide. It should be applied in a different context too. So to understand this, we need to understand what the context is when we want to shift to a different context. That is when you need to adopt and we need to reapply our minds. So next slide. So I'm going to break this up into a few parts. So how was healthcare before the pandemic? I'm going to talk to you purely on a doctor's perspective. Human interaction was the bedrock. Everybody felt that there has to be a face-to-face. The doctor felt it that way. The patient absolutely felt it that way. Protocols were considered sacrosanct, but actually, but that was only in academic circles. When people actually came to implementation, it did not happen. More was less. More visits, more tests, more equipment, more regulations. All of this was how it was before the pandemic. Extremely inflexible system. If the doctor says something, you got to follow it. So it's a very doctor-centric system. And as people have alluded to before, not only are we are not actually averse to innovation. We do use technology, but the technology has to suit our workflow, and then that's when we actually prefer. Otherwise, we definitely will kill any innovation before it even comes to the table. And right now, private healthcare is the preferred. I mean, before the pandemic, private healthcare is the preferred mode of healthcare, and there were multiple regulatory bottlenecks. So, what happened during the pandemic? Next slide. Yeah. Everything turned. Go back. Before. Yeah. Thanks. Everything turned upside down. No one wants to come to the hospitals and clinics anymore. So that takes away your face-to-face completely. And apart from providing care for the patients, it actually stops the generation of revenue for both the doctors and the hospitals. So that is something that nobody wanted to see. Visits for healthcare decreased dramatically, and this included emergencies. You're not seeing patients with heart attacks, strokes coming into the hospital. Why is that? We don't know that. So what has happened? Cost of healthcare has decreased. I'm sure most of you listening have not seen a doctor in the last 40 days for sure, and have not spent a single penny except maybe those who are on, what you can get from your local pharmacy. So what did all of this do? Telemedicine was suddenly accepted. People said, you know what, I need to provide care for my patients. My patients say I need to avail care. So telemedicine, so far we've been struggling to get it implemented in a big way. It has been, in fact, Devi Shetty was one of the pioneers who started it long time ago. In fact, more than a decade ago. And now suddenly there's a boom. Everybody is doing telemedicine. It's a fabulous thing that has happened during the pandemic. Innovation has boomed. All of you, everyone has spoken about innovation. Low-cost ventilators, low-cost PPEs. Absolutely great, fabulous. It's all been done fabulously well, and it's been done really quickly as well. So we are now having low-cost equipment. Regulations were relaxed. Before you know it, there's a telemedicine guidelines that have been floated. The PCP&DT, I mean, may not be the best thing to happen, but at least there was a slight change in regulations there. So a lot of things which were needing to happen happened thanks to the pandemic. So though this is a really bad time, I think it's a fabulous time for hitting the reset button for healthcare, especially so in India. I think now is the time when you see people the government and private are working together like no time ever before. Government patients in private hospitals, private patients in government hospitals. It is a fabulous thing. However, government healthcare has become the savior. From being the last resort for most patients, it has become the first resort for every patient. So that's a significant change. I mean, this is something that really something that needs to happen. So what should happen after the pandemic? Let's see that. So this is going to be the critical phase. just having this happen during the pandemic is not really going to solve our solution, because like everybody else, previous speakers have said, the pandemic eventually is going to go away, but our healthcare is going to stay. So what do we need to do? We need to reapply our minds and adopt quickly and consolidate the gains that all that we have achieved so far during the pandemic. What do I mean by that? Nitesh just spoke about the bag mask ventilation. I have personally seen in my career as a pediatric intensivist, children on a ventilator with the parents pressing the bag to keep their babies ventilated, purely for the lack of ventilators. And they used to do that for hours at a time, taking turns between father and mother. My questions were two. Why weren't these 70,000 bag mask ventilators available before? And what stops us from making them after the pandemic? I do agree that with Devi that sometimes we get familiar with equipment, but then I think having a ventilator of low cost, which is new to the system, in a government setup which does not have any kind of ventilator and expects the parents to do the bag and mask ventilation, will totally benefit and it will be a total benefit not only for the patient but also for the hospital system and the entire healthcare system. So whatever we have done now, whether it is protocols so that have been put in place, let's ensure that the telemedicine guidelines are fortified even more. In fact, if you look at the telemedicine guidelines today, it says that psychotropic drugs cannot be prescribed by telemedicine. The question is, why not? What prevents? It's the same psychiatrist who's prescribing the same medication to the same patient. Just the difference is the platform is different. Even otherwise, the psychiatrist usually does not have to do a physical exam. So in fact, if anything needs to be liberalized in telemedicine, it has to be in a specialty like psychiatry. So let's strengthen the guidelines that have already come out. Let's make sure that that is done. So what all these things will do is it will help healthcare to become affordable and available to all. So doctors, patients, and providers should learn to adapt to the new normal, and by adopting what has happened and whatever gains we've had during the pandemic. The cooperation between all the stakeholders, like I mentioned, whether it's the patient, the private healthcare, and the government healthcare, should all be working together. One of the things that I think most people have not mentioned, and this I will have to bring it up here, is the reason why innovation and technology has not taken off in a big way in India is because we do not have outpatient insurance. Everybody in healthcare knows outpatient healthcare is 90% of healthcare. 10% or so is what is inpatient healthcare. Lot of innovation is not getting done or implemented because we don't have outpatient insurance and there is no payer for it. So will the patient pay for it? Who is going to pay? Will the hospitals pay for it? Will the private hospitals pay? I'm not sure. So if we had outpatient insurance, that would be a big hurdle that can be crossed. And that's the need of the hour, because if 90% of our healthcare is not being covered by insurance, 90% of our people are not getting healthcare, which means preventive healthcare is out of the picture, and we are working on the tertiary healthcare or curative healthcare, which means you're behind the 8 ball. That cannot happen. And that is why we need to have outpatient insurance for all the things that we've spoken about today to happen. Next slide, please. So the questions to us and to the larger audience and to the government, to any stakeholder in the system, will we actually reapply our mind? Will we go back to where we are? Will patient behavior change? Will doctors change? Will medical societies and associations change their protocols and guidelines to make it in such a way that it is more cost effective and practical and meaningful? Will the private health sector change? Will there be more partnership with the government hospitals? Will we continue to encourage innovation? Will government sustain the changes that have happened, or is it going to change once the government changes? We need to be worried about that as well. Will we finally have affordable healthcare for all? I have questions here, and I'm not a prophet, so I'm not going to be able to answer the questions, but I think this is something that all of us have to think about. Last slide, please. For all our sakes, I hope the answer to the question I asked in the previous slide is a yes. And I hope we do what is required. Thank you so much, and I hope I stayed on time.
Thank you, Dr. Aravind. As usually, always, mesmerize us with some tricky questions. Whenever you are there on our discussions, I always say, like a doctor who doesn't hesitate to ask questions. So I have one questions from the audience. What are your thoughts on the future of using mobile technology for diagnostics?
Absolutely required. I mean, I think mobile platforms will become the way to go. And I'm a firm believer of point of care diagnosis. And there is absolutely no reason for patients to be coming to a lab, to a hospital for any of this. We can provide point of care machines, and they are ridiculously cheap. I mean, we have fabulous innovators within our ecosystem, young guys who have come up with, um, uh, paper-based testing or point of care testing, which costs like hemoglobin to be tested for 2 rupees, 10 rupees, which can then be loaded onto the mobile phone through the cloud. It is available to the doctor, it's available to the hospitals. So absolutely, mobile technology is the future of healthcare, not only for teleconsults, but even as command centers for the tele ICU that Dr. Shetty was talking about.
So we were listening to a lot many seminars and webinars in the last few days, and everybody is like, people are talking about the doctor's fatigue in these COVID times. But yet we see a lot less patients walking into the hospitals, which has reduced the burden for the doctors. And how is this trend going to be post-COVID scenario for the doctors? Do you have any say on how it's going to be on the footfalls, especially?
Yeah. So I mean, I think everybody talks of the much cliched new normal, and I think that is we really need to brace for that. And I think it's all good. I think visits to the hospitals were too many to begin with, and now people will think twice about coming in. And telemedicine is a great way of doing it. In fact, I wouldn't be surprised if doctors actually choose to say, I will come into clinic 3 days a week, 2 days a week, or 3 days a week. I sit at home and do teleconsults. And if I need to see any patients, the other 3 days, I will see patients who actually I need to touch, feel, examine, and do tests. So I personally feel that this will actually improve the quality of life of doctors. I think this is something that's going to happen, and I think it's a big positive out of this whole.
Yeah. If you have to say one technology which actually transformed the way healthcare is delivered in the last 1 month, what is that one technology?
Okay, I'm not a tech guy, but I think it's cloud.
Okay.
I think Great. The ability to do cloud computing has enabled us to do so many things. And I think all the things that were spoken about by the previous speakers would not have been possible if we did not have cloud computing.
Thank you, Dr. Aravind. Thank you so much for joining us. I think it's time for us to end a fantastic feast of activities, feast of sessions which have been presented by the eminent speakers and interesting entrepreneurs across in our webinar today. And all of you, I request all of you to go back to our handles, hashtag LHIF and hashtag India Productified, and also all the speaker handles which are posted on Twitter. And we also have NASSCOM Center of Excellence for COE and IoT and AI, and India product, NASSCOM product. These are the places where most of the discussions are posted. The videos are going to be posted. The team here is going to come back to you with the post event analysis to all the participants. And we are going to circulate the feedback form, and kindly fill in this feedback form and give us your valuable input so that we can improvise and bring out a better session, a much more enhanced session for you in the coming months. Thank you very much, for each one of you. People, do you have any of this form coming up on the screen, or is going to be sent across?
No, so we have a feedback form. As soon as the session ends, everybody is going to see a feedback form. Please do share it. It will take not more than 30 seconds of yours.
Okay.
So guys, thanks a lot. It has been a wonderful session today.
Yeah. Thank you very much, all the audience. Without you, the session wouldn't have been possible. Thank you very much for community from the NASSCOM community, and wish you all good luck. Stay safe. Stay happy. Thank you. Bye-bye.
Thank you all.